will start all over, and after Clarissa's talk, we can go to lunch. If we will look at the time, probably we'll make the lunch a bit shorter, so we end earlier in the afternoon. Oh my Lord, there is a lot of water here. So, okay. What else I have to tell you? I don't think, well, so let us start with the next talk by Professor Clarissa Yasuda. She works at Unicamp at the Institute Brain, which, okay, although it has two ends, its name tells you what the kind of research they do there. And she will tell us about neuroimaging and epilepsy beyond lesion identification. Okay? Okay, Clarissa, please.
So, thank you. I would like to thank you, Professor Yasuda, for the, can you listen to me? Is it fine? Not much? No, it's working. Yeah, I cannot talk too loud. Okay, so I would like to thank you, Professor Yasuda.
I mean, those in the back can hear? Those in the back can hear her well? Okay.
I would like to thank you, the organization, for the acceptance of my 3 students, Lucas, Italo, they are neurologists, and Thais, who is a med student, but she's an engineer. So they are very happy to be here with you. And at the beginning, I thought I wouldn't have anything to show because I do different research, but then Professor Yasuda said, oh, no, you should come and then show something. So you forgive me if it's completely out of the field, okay? And also forgive me if it's too shocking, okay? So I decided to talk a little bit about the epilepsy because I know that part of the program is related to epilepsy. And that's how I met Professor Paula years ago, before pandemics. And then I will talk a little bit about the other topics here. So epilepsy is, I may be suspicious, but it's a chronic disease that affects millions of people everywhere, but focus that approximately 80% of people with epilepsy live in the low and middle income countries, okay? So taking that in mind, we need to think about, because they are here. And the sad part is that 70% of these people with epilepsy, they could be free of seizures if they could receive proper diagnosis and treatment. So it's how we see. So they also have a lot of other problems, yeah? And this was from last year, but I checked it this year, and just the number increased a little bit. So the definition, I wanted to talk just briefly about the definition. And I wanted to stress that not all the seizures are synonyms of epilepsy, okay? So I will try to differentiate, because sometimes people get confused about, so seizure is the event, and then epilepsy is the disease, okay? So by definition, you can say you have epilepsy if you have 2 unprovoked seizures 24 hours apart. And so they extended the definition. You can have 1 event, but if you examine and do other examinations, and then you conclude that the patient will have at least 6% of having another event in the next 10 years, you can give the diagnosis with 1 event. And then there are other syndromes that I will talk briefly. Okay? So epilepsy, you need 2 seizures, non unprovoked. I don't know if any of you have seen a patient with a seizure, so I tried to.
Take a beat off of that. It's all right, Christy.
Okay. Have you ever seen some yes, some not? So this is an event. This is a seizure. And if you remember, the patient, she has a cap, and she's being monitored for investigation. Probably they would be considering her she as a surgical candidate. And so she starts doing like this, right? Did you notice this? Have you seen people having this? Okay, so what type of movement is this, Lucas? Okay, so she started doing this, and then she followed, then she has a tonic, and then she starts shaking, right? She started with mild, out of nothing, unpredictable movement, and then she evolved to this. So this is a convulsion. But I will show you some other events that are, not all the seizures have tonic-clonic movements, okay? So if you see here, so you have the definition of a seizure and then the epilepsy. So not all the seizures can be considered as epilepsy, okay? And I think this is also very important for you to keep in mind, especially for those involved in the investigation of epilepsy in general. Forgive me if you already know, I just want to stress. So we have to be able to differentiate because we have focal and generalized seizures, right? So this is the new classification, and we are not going through all of this. So we have the etiology, we have the types of epilepsy, and then the seizures types. Okay, what's important for now is that we can differentiate what is focal and what is generalized. And this implicates, of course, in the types of this. And the seizure type is defined according to the onset of the event. Okay? So if the event has a focal onset or a generalized onset, or sometimes we are not able to decide, so you can be focal, generalized, or unknown. Okay? So generalized onset. It means that the seizure can start at different points of the network, but it spreads very fast and they involve bilateral. So this is the definition of a generalized onset seizure. Okay. And that patient that we saw, that is one of the types of this type of seizure. Okay. And the focal onset. By definition, it originates within networks limited to one hemisphere, and it can be discretely localized, or it can also more widely distributed, and eventually it can also evolve to both the whole brain. Okay. So most of the time we are talking about focal onset, and the manifestation, it changes according to the location in the brain. As you are here, you are probably have been introduced to neuroscience, and then we have some areas in the brain that are related to motor or to this sensitive. This is the temporal lobe. Here we have the visual system. Yep, it's not, I don't think it could be new for everyone. So according to the place where the seizure is starting, it will be related to the manifestation, okay? So this is one type of seizure. This is a focal seizure. So what is happening? You can see there's a blink and then a tweet of the face of the boy. But he's awake, playing with the toy, but something is happening in the face, right? So this is focal seizure. And talking about focal seizures, I think this is also of interest for everyone to know that focal seizure can arise from any hemisphere, right, by definition, but 2/3 of the focal epilepsies, they come from the temporal lobe. This is important from the clinical point of view and also for the research. And again, when we think about temporal lobe, 2/3 of all temporal lobe, they arise in the medial portion of the temporal lobe. So remember, so we have the uncus, the amygdala, and mainly the hippocampus, okay? So this is how we talk about. So we have the focal seizures. Most of them come from the temporal lobe, and then when we go to the temporal lobe, most of them arise from the more medial portion. And this is a typical seizure I want you to see. Look at the mouth. She knows the seizure is coming. The hand, the mouth.
Lembra da palavra casa, da cor azul e desse objeto aqui, ó. Kelly, levanta o braço direito. Levanta o braço direito.
So the nurse is asking her to raise the right arm, but she's not obeying. She continues to move the hands.
Que objeto é esse, Lívia? Que objeto é esse?
She's asking her to recognize the object, but she's not responding.
Mostra a janela para mim. A janela.
Asking her name. Now she has nausea. She
Que objeto é
touched the nose.
Sabe que objeto é esse? Sabe?
Now she's talking again.
Esmalte. Sério.
Would you believe this is one type of seizure? Okay. Italo, what type of seizure? No. Yeah, so this is a typical temporal lobe epilepsy seizure with the impaired awareness, okay? And she did not pass out, she was not shaking, yeah? But this is a typical temporal lobe seizure. So I showed you a generalized seizure, then you have the boy with movements, and then this is the temporal lobe seizure, which is one of the most studied epilepsies, right? So for those who have never seen. I think it's nice to see the phenomena. And this is, can be very disabling for some people because it happens spontaneous, and sometimes you have some precipitators, but most of the time it is unpredictable when it will start, okay? So any questions about this clinical introduction, seizure, epilepsy, focal, generalized? It's fine. Okay, so I will touch a bit, talk a bit about neuroimaging. So this is where we do some of our research. Okay, I know it's not the main topic of the workshop or the school, but can give you a different perspective, can give you more inputs about that. Okay. So neuroimaging has evolved through the last decades, thanks to the physics. And first, very important role of neuroimaging is the diagnosis. We really need imaging to help us to either to confirm sometimes the diagnosis and to have it more in detail, and it also helps us to decide sometimes how to treat. So it's very important. Okay, so do you all know all about the temporal lobe? So we go back to a bit of anatomy. And for those who has already been talking about epilepsy, again, so this lower part is the temporal lobe, and we can see an MRI here. So we have on both sides, of course. And as I told you, this is the mesial portion, the more central of each lobe, and then we have here the hippocampus, okay? And, okay, so if you see here, we see a lesion, right? It's not the case right now. And why we call this hippocampus? Because this is, I dissected this as a project when I was in Canada. So this is the hippocampus in the brain. And because it is really, the shape is really resembles the actual hippocampus, okay? And this is probably one of the most studied, investigated structure in the brain, and most because of epilepsy. And for those, just to remind, the temporal lobe and the hippocampus is also very important to the memory, and is related to Alzheimer's disease. Okay. So hippocampal atrophy is probably the most frequent cause of and causes of a temporal lobe epilepsy with mesial characteristics. So we have, if you can see here, you see this is smaller than this. Can you notice this? And it is darker, so it has a hypo signal here, and it's brighter here. So this is how we visually confirm there is changes in this hippocampal, and we call this is hippocampal atrophy. And this is one of the most frequent causes of temporal lobe epilepsy, right? And why is this so important to detect? Because when we see this, the patient immediately has a chance to become a surgical candidate if he is not responding to drugs, okay? So we really need to find any type of structural alteration as soon as possible. And here, so it can happen like on the right side, on the left side, you can have it on both sides. And sometimes by visual inspection, it's normal. And even in this situation, you can have the clinical manifestation. So the brain is a mystery. Yeah, we don't know everything, but here we are. And the other thing that is important and that I wanted to bring here for you is to keep in mind that having temporal lobe epilepsy with that type of seizures is not synonym of having this, okay? It means you have a syndrome, which is a syndrome is a collection of manifestation. You have signs and symptoms. People can see, and the patient can refer what he's feeling, okay? But just by looking at the manifestation or by talking to the patient, we cannot confirm you have this. Because if you have the MRI, you can have some surprises. You have different lesions. So here you have a cavernoma, which is a vascular. You can have a type of tumor. You have a different type of tumor. And you can have a brain thrombosis. And you can have disease cystic circles. And these all can manifest the same way, right? So I think it's important for you to know that it's a syndromic diagnosis, and then we need the additional examination and clinical, and then you have the MRI, you have the EEG, and sometimes other exams to help you to narrow the etiology, the real cause of those seizures. So, as I told you, so the first main role of imaging is to provide you and assist you with a more precise diagnosis, right? I remove it from my talk, but as the former professor from Yale University said, you can have all types of accidents and brain injuries, and then sometimes you have seizures associated with that, okay? You have seizures, but not necessarily you are starting with epilepsy. Because the seizures that occur in the presence of any acute brain injury or systemic changes, we name those acute symptomatic seizures, right? But not necessarily epilepsy. Some people will develop epilepsy later, but not necessarily. So you can have a seizure because of that severe insult, but not necessarily you will develop epilepsy later. So epilepsy are the seizures that are unprovoked, okay? So for us to continue, we will talk about MRI. Then we have, so most of you are physicists, so it's good that I don't need to explain much. So we have the structural MRI, in which we have the differentiation, the detail here. And then when we talk about the functional MRI, it is fuzzy, right? Because here it's like 6 minutes to give you one image. Here I get the whole brain imaged in 2 seconds, right? So here in 6 minutes I am running 90, okay, so I can run like hundreds of images or photos of the image, and then I include here the 4th dimension, so I will include time here. So that's when we call this functional. So do I have a bit of time? So the first studies that used MRI to investigate the brain were those structures, and then they use the T1 images because the T1 provides you with a good contrast. We have the white matter and the gray matter very clearly, and then you can use different softwares to separate the white and the gray matter. And so the first method we call voxel-based morphometry. So you have the whole brain here. Then we use different algorithms. We separate the gray matter, white matter, the CSF. And then we go through different steps. We can modulate and do other things because we can get these individual maps for each subject. And having that, we can go to statistics. And then we can compare the groups, right? You can have a group of patients and controls, and then we can run statistics and see whether I can find regions of increase or decrease of these tissues, either gray matter or white matter. So this was a very old investigation. So just an example, there are hundreds of studies, not only epilepsy, but in all type of neuropsychiatric disease. So this is from 2010, from my PhD. I analyzed the pre and post op images, pre and post after temporal lobe seizure. And just to see, so in hot, in red, are the areas of gray matter atrophy before surgery. And this is a group of patients. We know that after surgery, it did not become seizure-free, and this is the group who became seizure-free. So even before surgery, although we could not see visually changes, in the group analysis, we could see that they had more widespread gray matter atrophy. So epilepsy is a network disease, because these patients, they had the disease, they all had temporal lobe epilepsy with hippocampal atrophy, though they all had the same type of surgery. But if you look, even before that, we see there's a bilateral widespread changes and atrophy. Okay, so this is just one of the example. And we will try to focus a little bit about the functional studies, and thanks to Professor already mentioned about that. So is anyone involved in fMRI study? Students? Okay, so it's kind of embarrassing for me to be talking to engineers and physicists in the audience, so forgive me if I use the wrong words and in my ignorance sometimes. Okay, so we use MRI, and then we program to make an acquisition with functional. And it is nice because we can get this type of image that will give us some information about blood flow and metabolism, right? Non-invasively. And we can repeat this. We can use for different type of subjects. And it also gives us a good spatial and some reasonable temporal resolution. What happens? So this is about physics. So you have resting, so you have the rest stage. But anytime you decide to do some task, that area of the brain demands more energy. So you need to give that region needs to receive more oxygen and glucose, right? So for that region that you decided to activate, there's an influx of the blood that comes full of oxygenated hemoglobin, right? So this is rest. When we are activating some region of the brain, there's an inflow of oxygenated blood. So we can say that this contrast, it depends on the changes of level of the oxygen. But it's not measuring exactly the oxygenated hemoglobin, right? Because the element that changes for the MRI is the oxyhemoglobin. So when there's a flow of blood full of oxygen, the oxyhemoglobin falls, and that is the reason that we can see the change of signal. So we have an indirect measure of oxygen changes in that area. So we are not measuring exactly the oxygenated hemoglobin, but we can calculate the changes in the desoxygenated hemoglobin. Does it make sense? Did I explain? So it's not a directed measure of oxygenated blood. When the oxygenated blood goes to a certain area, the paramagnetic, the oxygenated hemoglobin falls, and that is what we can capture with the MRI. Okay? So we are not, so it's an indirect measurement of oxygen changes, but not direct. And how we can take advantage of that? We can take advantage because we can, here, we can plan a paradigm task, And so this is very easy and very simple. We ask the subject to open and close the eyes at certain times. And then we can see, so when you open the eyes, there is an increase of the bold signal. When it closes the eyes, there's a drop. So it's programmed, right? Because we know, we instruct, so every 10 or 5 seconds, you need to open and close. And we can do this with different tasks. We can ask them to open and close the hand. We can do some language tasks, simple tasks, and then we can have some sensitive paradigms. So you need to alternate periods of rest and then the stimuli. And because the bold signal changes, we can calculate that, and after a lot of mathematics, we can find where those changes were happening, and then we can locate in the brain. Right? So this is task-related fMRI. And the second point is that the studies show it, is that so the brain is very intriguing, because when you activate like the visual or the motor or the language network, you also need to deactivate other network. That's how it works. You cannot have everything on at the same time. So when you decide to talk or when you decide to move your hand, you have a deactivation of this green-blue network, and then you activate like the language or the motor network. And after studying this with PET images and then with fMRI as well, this is recognized as one very important network. Who recognize this? So yes, so this is the default mode network, which is one of the most studied network, which needs to be deactivated when you engage in tasks. Okay? So there are diseases like Alzheimer's that progressively you are becoming unable to disconnect this, and then you cannot engage in the task. So we can use these other networks to investigate disease as well. Okay? So you have activated, and then you need to deactivate so the brain can work properly. So this is one study that I performed long ago in my postdoc in London. We used fMRI to investigate the effect of a drug, which is an anti-epileptic drug called topiramate. We had patients and controls, and we noticed that, so these are controls, during the language activation paradigm, it deactivates properly that network, okay? But patients taking the drug, so these are frontal lobe and these are temporal lobe, so they have less activation of the language network, and they do not deactivate properly the default mode. Okay? So we can use imaging to understand a lot of things. So this is what I wanted to show you. And this is non-invasive, okay? And then we said, oh, but can you be sure that it was the drug effect? So we were not sure. Then we have the same subjects and controls with and without the drug to confirm these findings, okay? And then the second part of fMRI studies, which may be the most popular right now, are those related to the resting state, okay? So we acquire the bold signal from the brain, but the individual, the subject, is resting. It's not engaged in any type of task. Why this is important? Why this is useful? Because even during the rest, the brain is not playing. There are a lot of networks that are activated, coming and going, and there are a lot of fluctuations in the signal, electrical, and the bold signal as well. So just to remind you, I should have used this before. So when you have the fMRI acquisition, you have sequentially scanned the the whole brain every like 2 seconds like this. And then what we do, we extract the bold signal for each voxel, and then we have millions or thousands of time series, depending on, and you can use that with different types of parcellations, as the other professor showed, okay? And what is the basis of the functional connectivity? Remember, we did not order any task, so the brain is just resting. But what we learned is that even during the rest, there are some areas in the brain, they are synchronized. For instance, we have, when we look, the spontaneous signal of the left and the right motor area, they are quite synchronized, okay? Even without any stimuli. And if we compare the time series from the left motor area with the left visual, which is posterior, they are not synchronized, okay? So I did that, so I extracted from one motor area and the other motor area, and then we found this. When I have motor area with visual area, even from the same hemisphere, they are not correlated in the rest state. And using that is how we can perform the studies of connectivity. So connectivity, we can separate the studies in structural, which depends on white matter tracts, which have been mentioned before. So this is structural connectivity. We can follow, we can see where the white matter tracts are going. Then we have the functional connectivity, that the type of connectivity we will be talking about. It's an information because we compare the correlation between different regions and see whether or not they are coherent or synchronized, okay? And the important thing here is that when we talk about functional connectivity, we cannot infer anything about directionality. So we don't know if it's this region that started the signal and ordered this one, or vice versa, okay? We can only infer that somehow two or other areas, the signal is fluctuating with the same frequency. But we cannot say which one is ordering the other, which one comes first. Okay, so if you want to do that, we need to study effective connectivity. This is another word of math, statistics, and physics. Okay? So this is a paper from Carl Freestone from London, and it is there's a very nice explanation of all this type of connectivity. So coming back to functional connectivity, there are several ways of studying, analyzing that. We can use a seed, so you can extract your time series and ask for the program to see what are the other areas in the brain that are fluctuating at the same frequency. Then you have a map. So this is the seed method. You can also use other methods like because you can have independent component analysis because it is there. The networks are there, especially when we're talking about normal volunteers. And there are different types of networks that exist even during the rest, okay? The most studied is the default mode network, but there are others, so just so you know, and they are all very important. The most important is this. The most important, the most studied is this here. So in considering epilepsy, so this is the work of Bruno, who is a physicist in our lab. He developed a MATLAB, like a toolbox to help us to analyze fMRI, both resting state and task related. And then we analyze it left medial temporal lobe epilepsy and right temporal lobe, and then we investigate the changes in these networks. So he used a different parcellation method. He selected a map with 70 ROIs based on 12 networks, extracted the time series from those 70, and then we could go through that and get statistics and comparisons, okay? So when we look the right TLE, these are changes, and we are looking at the blue means reduced connectivity between areas of the brain compared to controls. So these are the 12 networks, and combined, he created 70 regions of the brain to cover all the 70, okay? And then when we look at the left side, not the left side, but this is the people with left temporal lobe epilepsy. And somehow, if we look here, we see more changes when people have left hippocampal atrophy compared to when they have right hippocampal atrophy, okay? And this is a finding has been noticed that even when we studied gray matter, white matter, and other types, most of the groups can see that when you have left temporal lobe epilepsy, you have more widespread bilateral damage than when you have right hippocampal atrophy, okay? And just I'm finishing. So this is another research that we performed. And different from that, instead of analyzing temporal lobe epilepsy, we investigated people with generalized genetic epilepsy. Okay? And so this is exactly on the type. Remember the first video, the first seizure? So those type of seizure. And again, so we just see here that when you have that epilepsy and also have anxiety and depression, you have more alterations, okay? And so in conclusion, I wanted just to remind you that not all the seizures are similar synonym of epilepsy. We need to think about difference when you are talking about or studying focal or generalized. When we consider focal epilepsy, side matters. So for all those involved in studying, when you have a focal epilepsy, you need to see which hemisphere, and sometimes we cannot analyze all of them together. Sometimes we need to flip, so it's important to consider the side. It is a network disease. It affects the whole brain, and both comorbidities and drugs can affect all these networks. So thanks to all of this and to our funders. Thank you.
Thank you. Thank you, Clarissa. I mean, thank you for a very nice talk. So for many of us who just do the physics, I mean, explaining how the medical doctors do their experiments. So please, any question? Well, okay. Thank you very
Thank you.
much.
I thank you.
Now, in principle, we as